Hi, my name is Dr. Nate Pennell. I'm a medical oncologist at the Cleveland Clinic Taussig Cancer Institute in Cleveland, Ohio. I run the Lung Cancer Medical Oncology program here. Today I want to talk to you about plasma testing, or so-called liquid biopsies, for broad genomic testing in lung cancer. So what do I mean by broad genomic testing? Basically what this does is, instead of testing for an individual mutation such as the EGFR mutation for lung cancer, you can test for either a dozen, 30, 50, sometimes hundreds of genes in a single test that looks across the entire genome of the patient. And this is often used to try to identify something that can guide the treatment of the patient, to target individualized therapy. And we know this is important in lung cancer because there are lots of potentially targetable mutations in patients with lung cancer that we can exploit. For plasma testing, this is a really exciting field because traditionally, in order to do broad genomic testing, you have to get a biopsy, an actual piece of the patient's cancer, to do this test, and it sometimes takes a few weeks to generate that data. Wouldn't it be great if you could just do a blood test and actually detect the same thing? And it turns out you can, and there are a number of companies out there that have made tests that can detect DNA that's circulating in the blood that's released by the cancer and can detect the same kinds of mutations that you find in an actual biopsy of the cancer. There are some issues with this that have kept it from being broadly applicable to everyone with cancer. Probably the most important one is that it's not perfectly sensitive. So you can trust it if you find a mutation. For example, if you find an EGFR mutation in a plasma test, you can believe that and you can treat someone based on that. However, if you do a blood test and you don't find any targetable mutations, you can't trust that you haven't missed it. Not every tumor sheds DNA in enough quantities to be detected in the blood. And so if you do that and you don't detect it, you still have to go back to a tissue biopsy in order to be sure that you're detecting everything that may truly be there to help guide that patient's treatment. So where is this really useful today? So in 2017, probably the best use for broad genomic testing is in the patient who doesn't have enough tissue left to do testing and really doesn't have either the time or it's too dangerous. They're perhaps on blood thinners and it's very difficult or dangerous to stop, or they don't have enough cancer that's in a place that's easily reachable and you really have a high suspicion that they have a targetable mutation. So a non-smoker, someone who quit smoking decades ago would be a good person to do plasma testing if you don't have enough tissue for testing. But again, if you do the test and it comes back negative, always keep in your mind that sometime later on you're going to need to get another tissue biopsy to be absolutely sure that they don't have a targetable mutation. As these become more sensitive and less expensive, I do think that this is probably the future of testing for lung cancer.